Hello, my name is Nizhoni Denipah. I am an otolaryngologist here in Santa Fe. Otolaryngologist is also known as an ear, nose, and throat, head and neck surgeon. It's a little bit of a mouthful. Today, I want to talk about tonsillectomy in pediatric patients or in children. I've got a few objectives. I'd like to talk about the background of tonsillectomy in pediatric patients. What is the anatomy of the tonsils? Where do they live? And what do they do? Indications for tonsillectomy. So why would we take the tonsils out in a pediatric patient? What does surgery look like? And then how do you get a patient evaluated for tonsillectomy, or what does that entail? So going to the background, tonsillectomy is the second most common surgical procedure in pediatric patients in the United States. Ambulatory means basically the patient goes in for surgery and then goes back home the same day. In some cases, depending on the reason why a child needs their tonsils taken out, they may stay overnight in the hospital. In the United States, the number of tonsillectomies has declined since the 1970s. So for example, in pediatric patients that are under the age of 15, in 1965, 970,000 tonsillectomies were performed in that year. In 2010, which was 10 years ago, 289,000 tonsillectomies were performed. So there was a big drop from that time difference there. And then I also want to make sure that I note that the indications or the reasons why a pediatric patient may have their tonsils taken out are not the same indications that an adult would have their tonsils taken out. And so this talk applies only to pediatric patients. So let's go over the anatomy of the tonsils. So in this picture, you can see the teeth up high and the teeth down on the bottom. You can see the tongue, which is not labeled, and then up top, you see the hard palate, which is up in the front of the mouth, and then the soft palate, which is a little bit further back. Attached to the soft palate is a little dangly thing in the back of the throat called the uvula. And then on either side of the uvula and behind the tongue is where the tonsils live. And you can see those are clearly marked there. Now I have another picture of the tonsils, but I also want to point out where the adenoids are, because many times in pediatric patients, the adenoids are taken out with the tonsils. And so you can see on the right side of the screen that the adenoids sit in the very back part of the nose. Those are sometimes often taken out with the tonsils. What are the indications for tonsillectomy? So the reasons why one might take out the tonsils in a pediatric patient are for sleep disordered breathing or obstructive sleep apnea, which can be caused by very large tonsils. We'll talk about that in a little bit more detail. Recurrent acute tonsillitis, so lots of infections of the tonsils. And again, we'll talk about that one in greater detail as well. Peritonsillar abscess is a very severe infection that is associated with tonsil infections that often requires drainage of an abscess, and that can be an indication for tonsillectomy. Tonsillitis or a tonsil infection can be associated with very high fevers, and so sometimes children will get a seizure associated with that high fever. If that were the case, we would definitely consider taking out the tonsils for that. Sometimes kids can have trouble swallowing because their tonsils are large, and so that would be an indication for taking the tonsils out. I would warn against presuming that all swallowing problems are associated with the tonsils. In a kiddo that is having trouble swallowing, I would like to make sure that any swallowing issues are completely evaluated, so that way we don't just assume that the tonsils are the culprit. There can be lots of reason for swallowing trouble. Very uncommon in pediatric patients are a concern for malignancy or a concern for cancer in the tonsils. That's more common in adults, but we have very rarely occasionally seen it in kids, and so that would be an indication to take the tonsils out. And then finally, chronic tonsillitis, which is a very prolonged sore throat, often lasting months. Generally, I have my patients try and do some techniques that can get rid of that sore throat before we move forward with a tonsillectomy. I generally like to observe the patients for 6 months to a year to see if we can't get them over that sore throat before we move forward with taking out the tonsils. So sleep disordered breathing and obstructive sleep apnea are one of the most common reasons why we take out the tonsils in kids. So what is sleep disordered breathing? Well, the definition is written there for you. It's abnormal respiratory pattern during sleep that can include snoring, mouth breathing, and pauses in breathing. So you might see this in your child when they're sleeping, that they're snoring loudly, they're holding their breath and kind of gasping for air. Maybe they're moving around a lot in bed and tossing and turning. Maybe they're snoring and having trouble, and then you find that they're getting up and moving from their bed to your bed. That can be an indication of sleep disordered breathing. Obstructive sleep apnea is basically sleep disordered breathing that's been diagnosed by polysomnogram. There are certain criteria that must be met for the diagnosis of obstructive sleep apnea. So it's basically patients have symptoms of sleep disordered breathing, they're sent for a polysomnogram, and then they meet criteria for obstructive sleep apnea. So in a patient that has sleep disordered breathing or obstructive sleep apnea, you might see that during the day they're hyperactive, maybe they're seeming like they're tired all of the time, they're falling asleep very easily in the car, they can be inattentive or have poor school performance, sometimes they can have behavioral problems, maybe they're consistently hard to wake up in the morning, to get ready for school, or maybe they're a mouth breather. They're constantly breathing through their mouth even when they're sitting at rest and not really, having a lot of exertion and activity. What happens if a kiddo has obstructive sleep apnea and it's not treated? Well, sometimes in severe cases you might see a little bit of developmental delay. You might see some failure to thrive, which means maybe your kiddo is not gaining weight appropriately. They're having a hard time breathing and swallowing at the same time. In severe cases, you might see that there's lung and heart complications. That is a lot of times seen over the long term. And then again, we talked about behavioral disorders. Recurrent acute tonsillitis is, I would say, the second most common reason why we take out the tonsils, and there's pretty stringent guidelines around what is recurrent acute tonsillitis. So it can be 7 infections in 1 year. That's a lot of time being spent in the hospital. The second thing that it could be is 5 infections a year for 2 years in a row. So obviously you would be kind of watching your child if they didn't meet that 7 infections a year, maybe they're having 5 and the second year is looking like they're still having a lot of infections. And then next is 3 infections a year for 3 years in a row. The other thing that we might think about taking the tonsils out if your kids are sick enough that they're missing more than 2 weeks of school. Generally, this recurrent acute tonsillitis, we are watching the patients for about a year or more, but that's not necessary depending if there are complications associated with a severe infection. So surgery, what are the general expectations or what can we expect during surgery? We're taking out the tonsils which are in the throat, and so you can have pretty severe throat pain for up to 2 weeks after surgery. I often tell people that their throat may feel sore for up to 4 weeks. There's lots of muscles in the back of the throat that are associated or they're involved with speaking, swallowing, breathing, and so there can, with that scar tissue healing, there can be a little prolonged throat pain there. It can be normal to have some ear pain associated with taking the tonsils out. A lot of times people notice that they have stinky breath for about 2 weeks after surgery, and that's because there are scabs on the back of the throat. The mouth is a dirty place, and so those scabs collect bacteria and it becomes stinky. It doesn't mean that the tonsils are infected or the area where the surgery is infected. It just means that those scabs are collecting a little bacteria, and that smell will go away once the scabs come off. The other thing that can happen right after surgery is post-operative nausea and vomiting. What are the risks of surgery? So what are the things that we worry about associated with surgery? And these risks of surgery are pretty rare. So some kiddos can have delayed feeding or get dehydration after surgery. That's most commonly because of pain. And so we try and make sure that our kiddos have good pain control after surgery so we can prevent the dehydration and things like that. Some kids will notice that their voice has changed. That may change temporarily, permanently, or it may go back to normal afterward. One of the biggest complications that I always make sure that I talk to patients and parents about is bleeding after surgery. And so bleeding occurs in about 1 to 3% of patients that have their tonsils out, and we consider it an emergency. And so I think it's always important just to mention that because it is a risk of surgery. And then, of course, there are risks associated with going under anesthesia, which the anesthesiologist is better at talking about. So evaluation for tonsillectomy, what does that entail? Generally, I recommend that your child or the pediatric patient is initially evaluated by their pediatrician or primary care provider. What they can do is they can document a lot of the data associated with the infections. It's documentation of the number of infections that a child is having in a year. They can order studies to evaluate, do they need a sleep study? Do they need a swallow study? Are there other things that can be done to prevent these tonsil infections before coming to see us? If the pediatrician or the primary care physician feels that they do need their tonsils out or they may need further evaluation by a specialist, such as myself, then we're happy to see them. Every patient is an individual, so we evaluate each patient independently. Their clinical scenario may be different, and while there are guidelines for taking out the tonsils, they're not necessarily hard and fast rules. And so we like to look at the entire clinical picture before we decide whether your child will need a tonsillectomy or not. Patients may require a little bit more of a workup after they come and see us. So, maybe they don't have a sleep study yet. We might want to send them for a sleep study, or maybe we want to send them for a swallow study. Maybe we want to, they're not meeting criteria, so we watch them for a little bit longer. So those are things that we might do when we see them. I did want to make a note that just because a child has big tonsils does not mean that the tonsils need to come out. If a child has big tonsils, they're sleeping very well, they're doing great in school, they're not snoring, they're not having any behavioral issues, they're just a great normal kid, let's leave those tonsils alone. They're not doing any harm. As an example, this is a picture of me and my daughter several years ago. Both of us still have our tonsils, so they're not always bad guys. If they're not doing any harm, we just leave them alone. I look forward to meeting you or your child in the future if it's indicated. I'm sure my colleagues would be happy to see you as well and evaluate the need for tonsillectomy if it's indicated.